For those here in person and those virtually, welcome. It's a pleasure today to introduce my colleague, Dr. Anna Rahmani, whose interests in thrombosis are now becoming legend since she's arrived here as a member of our division of general internal medicine, and her interest was in thrombosis. She's become more prominent in that area and has attracted a variety of other physicians to work with her in thrombosis. She's now head of the Division of General Internal Medicine at St. Paul's, and will be speaking today, as you can see, the clot, the heart, and the scalpel. I neglected, I'm sorry, to give a land acknowledgement, and so we acknowledge that we are gathered and are grateful to live and work and play on the traditional and ancestral and unceded territory of the Coast Salish people. Anna.
Thank you. Thank you very much, Dr. Caston. Well, thanks very much, everybody who's here. Happy Halloween. Hopefully your Halloween is a fake bloody with lots of good thrombosis at the end. So I was going to do the same in terms of land acknowledgement. We've done that. So I'm also grateful to live in such a beautiful land. I have the privilege to raise my children here. These are my disclosures. I do have some consultative support from pharmaceuticals and educational funds for the thrombosis clinic here at St. Paul's Hospital. All right. This is a very brief overview of what I'm going to talk about over the next 45 minutes or so. And the first part of it is actually going to be more focused on the pathophysiology of arterial thrombosis. Not so much because I want to put you all to sleep during lunch hour, going over the mechanics and the molecular biology of a thrombus formation in arteries, but more because the knowledge that we have gained over the years has led to understanding how complex a thrombus formation is and how that formation actually is going to affect what we do at the bedside and the implications that it has for treatment and management of patients that are experiencing specifically arterial thrombosis. And then I'm going to switch gears and talk about an area which is a bit of an orphan in terms of arterial disease process, which is unexplained arterial thrombosis. And it's going to be a bit anticlimactic because it is a very exciting area, but it is an area that comes with very little research. It's not quite as sexy as stroke and acute coronary syndrome, but it is a very relevant area because we are finding that the morbidity associated with the disease process of unexplained arterial thrombosis is just as significant as any other arterial event that patients experience. And then present some of the expert opinions in terms of how do we manage these patients, for the simple reason that, as I said, I won't be able to show you New England Journal randomized controlled trials in terms of how we manage unexplained arterial thrombosis. And that's all to set it up to say that we absolutely need to have collaborative work on this, especially in our institution. We do have the pleasure of having hematology, cardiology, vascular surgery, and hence the title of the heart, the clot, and the scalpel in terms of managing patients that are presenting with unexplained arterial thrombosis. So I think within this group, I don't really need to convince you that thrombotic disease remains a major contributor in morbidity and mortality of cardiovascular disease. In fact, 1 in 4 Canadians die from the thrombotic complications of cardiovascular disease in form of myocardial infarction, stroke, and pulmonary embolism. And thankfully, we have moved quite a far away from what Virchow tried to do by basically visualizing a gross thrombus at the time, a venous thrombus, and really beautifully coming up with a very simple triad of hypercoagulability, endothelial injury, and stasis, which we traditionally have thought about in terms of venous thrombosis. And although this triad has stood the test of time, what has happened, thankfully, over the years, both at the bedside and at the molecular level, is that we've been able to add a significant amount of information to that triad. And part of that information has been that there is potentially and likely the same triad functions when an arterial thrombus forms, and it is probably responsible for some of the unexplained thrombosis that we're going to talk about as we go forward. So it is not just a triad that has come a long way. the traditional and simplified coagulation cascade that we learn in medical school, I'm sure you all have memorized by now, with the idea of the activation of the platelets by exposure to tissue factor and initiating the extrinsic pathway, or potentially a contact activation from the extrinsic pathway, all of which leading to exchange of or our transition of prothrombin to thrombin, and then eventually the breakdown of fibrinogen or cleaving of the fibrinogen to fibrin has also come a very long way. And in fact, it has come a long way from even when I was a thrombosis fellow. So traditionally within the world of thrombosis, when I was in medical school residency as a fellow, we tended within the thrombosis world to really separate what an arterial thrombus versus a venous thrombus is going to be looking like and who's going to look after it. So as a thrombosis fellow many moons ago, I had a cognitive line in between this very simplified slide. So to me, the arterial side is going to be cardiology, neurology. They're going to kind of do their thing. And I would never get a call to go in as a bedside of the patient that was experiencing an arterial thrombosis, because traditionally within all institutions, anatomical presence of the thrombus drove who and what is going to look after that patient. So if it was within the brain, it's going to be neurology. If it was in the heart, cardiology. And if it was in the limb, it was going to be my vascular colleagues who are going to show up to rescue that patient. My world existed more on that venous side. So in the understanding of the venous thrombosis, how to go about treat it and how to manage it. That line has become quite blurry. And in fact, I would argue it no longer exists. And that's absent, the progression towards understanding the differences between venous and arterial thrombosis has actually come from the bedside. So there's been a lot of information in terms of what is the molecular mechanism by which the body makes clot, but the beautiful work has come from the bedside when we were able to do thrombectomies. So this is a work that was done where patients basically would present with ST elevation MI. And at the time of their presentation, they would go to cath lab, and the cardiologist would then would do a thrombectomy. And upon extraction of that clot, they would take a photo. And so this is all comers, they're all coming in with ST elevation MI. And as the clot is being extracted, one of the first things that they notice is that although the clinical presentation is the same, they're all coming in with chest pain, there's evidence of ST elevation on the EKG, the patient has a different type of thrombus when they extract it. And so these have traditionally been known as white thrombus or red thrombus. And the difference is basically, as you can see on A, that is I don't know how the color looks up there, but that's supposed to actually be white. So whitish color thrombus traditionally has been thought to be a thrombus that is mostly made up of platelets and fibrin, as compared to the red thrombus, which is mostly made up of red blood cells. And so this was very interesting because from a clinical perspective, we don't really think much about, is this a red thrombi or is this a white thrombus? We are going to put the patient on an antiplatelet therapy, and if there is an indication, an anticoagulant, and call it a day and let them go. But in fact, the difference in the types of thrombus and what that composition of that thrombus has been shown to be significant to how well we're able to treat and how successful our treatment is. So how did we come about to figure that out? So these are the same set of patients. So now the thrombus goes down to the pathology. They fix it, and now they're going to look at it under an electron microscope. There are different types of thrombus here. So panel A and B are showing you a thrombus that was extracted by a vascular surgeon, and it located over an aneurysm within the aorta. And so on that extraction, what was very interesting was that the laying down of the fibrin within this area is actually different when you come across the layers. So the body is actually making very specific decisions in terms of how they're going to lay down the fibrin. Within the concave of the aortic aneurysm, there is a lattice of fibers, as you can see in B, right? So it's basically trying to use the lattice to fill up that hole. And then when it gets to the top of the thrombus, it actually realizes that I am now at the edge of the endothelium, and now I have to make a different decision. And the laying down of the fibrin becomes linear. Makes sense, because if you think about it, the largest blood vessel in the body, the aorta, has the velocity, the blood velocity is 4 meters per second. So whatever you're laying down has to be able to stand a 4 meter per second velocity of blood going over it. Otherwise, you're going to have a morbidity, meaning an embolic event. And so beautifully, the body says, I'm going to fill the hole with this type of lattice, but then I'm going to lay a layering effect of fibrin to be able to reduce the contact friction that occurs with the other rest, with the rest of the components within the blood, because I really don't want to activate more platelets and actually expand this clot into something bigger. And so we're going to come to talk about kind of what happens when that goes wrong, and then you have a dangling thrombus sitting in your aorta. So follow up on that, then they can start to look at some other types of thrombus. We're not going to spend too much time on the venous side, but panel C is basically a clot that was extracted from a mouse with an injury to the IVC. And so when you actually zoom into a higher resolution, what you find is that, as you can see, there's very high levels of RBCs as compared to like up here where you rarely see any RBCs. So very high number of red blood cells are trapped within that fibrin lattice, and then that there is actually also a layering effect on top of that. So there is also a response of forming a fibrin layer on top of the thrombus, even though it's in the venous system. So why does this matter? It matters because now that we have done these studies, we actually now know the response to treatment in form of thrombolysis actually is going to be completely dependent on which type of clot you are trying to lyse. So the higher the level of fibrin, the more organized the clot becomes, the less likely you are to be able to actually disrupt it with thrombolysis. And so this is not unusual for us to see that even though a patient might have a pretty fresh clot, and they go into a procedure room, either the IR person or the cardiologist comes out and says, I couldn't really get this thing to lyse. It wasn't really responding, as compared to patients who have a very successful response to thrombolysis, and you're able to restore flow for them. So this is an area where I actually wanted to bring this up, because it does have immediate effect in terms of when we are at the bedside and trying to offer treatment to our patients. So the formation of fibrin and our discovery of layering and what type of form of fibrin gets deposited is not just limited to a response to endothelial injury. In fact, our body has, for however millions of years we've been evolving, has been using an immunomodulation of thrombus formation for control of disease processes and or as a response to infection and inflammation. And that is mostly driven by our monocytes, where an inactive tissue factor can become activated when the monocytes are exposed to either pathogenic or a damaged antigen, where they say, this is not something I recognize, this is not a good thing, I need to control this. And with the exposure to the PAMP or DAMP, so either pathogenic or damaged antigens, the tissue factor becomes activated. The floating tissue factor basically results in activation of the platelets, and with that, the whole coagulation cascade gets initiated. With the initiation of coagulation cascade, a lot of other cofactors, which I'm not going to go into, get initiated, and the end result is a formation of a fibrin clot, whose purpose is to act like a little cage. And it's meant to be controlling what's happening within that local site, if it's in effect a damaged tissue, if it's presence of bacteria or any other pathogen that the body needs to take control of. So this is, you probably will be hearing about immune thrombosis, and this is a very brief overview of how within arteries we take advantage of contact pathway to use coagulation cascade to control a potential sepsis or an exposure to a foreign material. All right, so it is not just the fact that we are, experiencing different types of thrombus within the layering of it, let's say an aneurysm. It's even more complicated than that. Like if you actually go in and extract the clot from different parts of the body, the type of clot is different. This is fascinating to me. The body seems to know I am in the brain, so I'm going to lay down clot that is this type of a clot. And so when they went in and actually analyzed the different types of clots from patients who had stroke versus those who had a myocardial infarction versus those who were experiencing a ischemic limb, or if they had a pulmonary embolism, the findings within the clot were different from each other. And when you extracted the clot also made a difference in terms of what the composition of the clot was. That is not too surprising. We know that there is an instability to the clot as time goes by. For example, in the venous thrombosis world, we know that if a patient is presenting with a DVT on day 2 and it's massive, we have a much better chance to have our vascular surgeons go in and lyse it, because the fibrin deposition and the level of density of fibrin is not quite there, and they're able to have a successful thrombolysis, as compared to a patient who shows up 10 days after they become symptomatic. And we know from our studies, and as well as, you know, just expert opinion, that the likelihood of response to thrombolysis drops significantly. And so that also is a reflection of what they're trying to show here, which is the shorter procedure versus longer procedure in terms of trying to do an embolectomy on a patient. And so the level of fibrin that gets deposited as time increases, which is not a surprise, because what you want to have is a stable clot. But do you always get it? And the answer is, well, sometimes you do, sometimes you don't. So we're going to get to that. But I just wanted to very quickly review that, you know, within clinical world, we kind of look at a stroke as an arterial event. A cardiac event in form of a myocardial infarction is another thrombotic event in the arteries. But in fact, when you go to the molecular level, the deposition of the molecules at the anatomy, at the anatomical site, remains very different. And so the reason that I'm pushing this is because as we get to the second portion of this, which is unexplained arterial thrombosis, it is a little bit frightening when we're trying to guess what would be the right treatment for the patient, because we actually don't know what is the composition of clot. And it potentially makes sense that not every antiplatelet or not every anticoagulant will be able to successfully treat different types of clots with different compositions. So in terms of not only just the formation of the clot, there is further complications in terms of understanding an arterial clot. It's not just about kind of forming that clot and trying to rescue an endothelial injury or prevent your patient from hemorrhaging, but it also has to do with, in addition to hemostasis, which is the original formation of the clot, it's the stabilization of the clot. And so that part is kind of like the second half once the clot forms. And that's the response of the body in terms of, I'm going to just go crazy here and I'm going to deposit as much fibrin as I can. I'm going to have a really beautiful stable clot. That's fantastic. Well, there are issues with really creating a very highly dense fibrin-rich thrombus. And that is that, yes, I've made a beautiful, you know, cover for that plaque or potentially for that damaged endothelial, which I thought I was going to hemorrhage from. But if I'm going really overboard, I'm going to potentially occlude that blood vessel. And without occlusion, obviously, comes the morbidity of everything downstream from it is now going to be ischemic. Okay, so it's nice to have the stability of a clot, but you're now causing more morbidity with it because you're cutting off flow to the rest of the organs downstream from there. The other potential is that you make it so huge that the actual size of it becomes a problem, and that eventually it kind of tears off and flies away. And so although it was originally a stable clot, if you just have an uncontrolled level of production, you could potentially actually make it too big where it becomes unstable from that. In terms of the instability of the thrombus, the thrombi that tend to embolize, and when we are able to do studies on them, are the ones that have the composition that's made mostly from lattice of the fibrin, and there is a lot of porous formation with a lot of RBCs within them. And so the wiggly thrombus, I can kind of see it in my head, is not really supported with a very strong fibrin structure, and so it remains very vulnerable to flow potentially or any other local risks. And the other worrisome, I guess, events related to an unstable thrombus is that it actually has the potential to become a shower, an emboli, because you can have pieces flying off, right, and one large piece flying off. And so you remain somewhat vulnerable to the effects, after effects of a thrombus formation. So that also matters in terms of prevention of future events when we are kind of dealing with patients that are presenting with arterial thrombosis. And so all of that to say, it complicates things because majority of the world had lived with warfarin up until 2013. It was nice because we didn't have a choice, right? People would come in and all you had to give them was aspirin and warfarin. So you really weren't really struggling with too much. You could just say, that's all I have, that's all I'm going to give you. And so that was the gold standard of treatment. But the introduction of the direct oral anticoagulants, which has been great and are now the first line therapy for both arterial and venous thrombosis, is made it possible for us to now have an option. But with that option is the limitation that all of the studies that have been done within the arterial world have been limited to atrial fibrillation. There is really no studies that are looking at arterial thrombosis that are unexplained or are in areas that, as we're going to see, haven't been really studied. So we have major high number of studies, over 14,000, 18,000 patients that have been studies with rivaroxaban, apixaban, and edoxaban, and all of them are population limited to a very specific disease. And the reason that I brought up the pathophysiology of the thrombus is because I actually worry when I see a patient like that are these anticoagulants good enough to be able to treat a thrombus that is not what an atrial fibrillation thrombus look like? And so what are we going to do with patients that are presenting with that disease process? And not only that, I know what to do with AFib. I know what to do with pulmonary embolism. But if a patient is coming in absence of really a clear risk factor that explains their arterial thrombosis, once I've treated that patient for a period of time, what do I do? Can I stop their anticoagulation? What is their risk of recurrence? Or am I increasing, by keeping them on anticoagulation, am I increasing their risk of bleeding? And really, we do not have a true answer to that, for obvious reason that they are rare, but they're very devastating disease processes, and they remain really an orphan. So from an arterial thrombosis perspective, I tend to think of events that are, bread and butter, as acute coronary syndrome, myocardial infarction, atrial fibrillation, LV thrombus in the background of a ST elevation or non-ST elevation MI, and mechanical valves, all falling within the umbrella of cardiology. Strokes and TIA within the umbrella of neurology. Vascular surgery steps in when our patients show up with acute limb ischemia or peripheral arterial disease, and thrombosis and hematology share the thrombophilias with antiphospholipid antibody syndromes and heparin-induced thrombocytopenia. So those are kind of like the bread and butter of every day. We have data for most of them when we know how to treat them and for how long to treat them. But then there's this entity of unexplained arterial thrombosis. These are patients who present often very young in absence of any disease process. And they are showing up with aortic thrombus, cryptogenic strokes, visceral infarcts, arterial thrombosis in the background, inflammatory associated disease that is well controlled. And so do we actually see them? And in fact, we do. So these are patients that I have personally been involved in their care, and has led to kind of my interest in understanding the pathophysiology of unexplained arterial thrombosis. So my very first case actually was referred to me by Sean McDonald, one of our vascular surgeons here. This is a 54-year-old woman presented to MSJ with syncope, and upon arrival, her hemoglobin was 49. And so they did a CT scan mainly because they wanted to know where the hemoglobin went. She had no history of ever having melena, no bleeding events. So they did the CT scan to see if she had retroperitoneal bleed. And the CT showed a nice, beautiful dangling thrombus within the aorta. Cryptogenic acute limb ischemia, another referral from our thrombosis, from our vascular group. This is a healthy 48-year-old woman, no past medical history, that showed up on the popliteal artery thrombosis in absence of any disease process. Cryptogenic stroke. This case still haunts me to today. It was actually on CTU a couple of years ago. Physiotherapist, 32-year-old man, was out with his friends, drinking beer, had a right MCA stroke, and in absence of any disease process or risk factor. He was referred to thrombosis because neurology just couldn't come up with any other reason as to why he had a stroke. This was a really sad case, 42-year-old healthy man, unfortunately presented with abdominal pain, and eventually was diagnosed with superior mesenteric artery thrombosis in absence of any disease process. An extremely morbid issue. He lost almost all of his small bowel. And it was a very difficult case and to see, given the significant morbidity that this young man experienced. And then again, these are all very young people, 35-year-old teacher. She was teaching and all of a sudden her right eye just went blind. And so she was diagnosed with right retinal artery occlusion. And we were seeing her because we're trying to figure out, can we explain why she experienced all this? And so as you can see, although the overall burden of disease in terms of the numbers that present to the emergency room are small, they're not your bread and butter of patients coming in. Once they do show up, they show up with a highly morbid disease process. And so when it comes to arterial thrombosis, I would say that thrombus seems to be one area where multidisciplinary and multiple subspecialties can be affected. And now, in addition to all of those kind of very unusual thrombosis of unusual site, if you will, we now have very good data to show that our cancer patients are at risk of experiencing arterial thrombosis. So from oncology to neurology to cardiology to vascular surgery, and now with our ability to be able to really support our pregnant patients with mechanical valves, we seem to straddle multiple disciplines whereby patients with thrombotic disease remain vulnerable. And so the reason that I feel like this is important is because we potentially, as thrombosis medicine, can be the group of people who can provide that kind of umbrella care. And I am a bit biased because I also am a general internist and feel that as a double specialty, we're probably really well positioned to create a collaborative care model with all of our colleagues to really bring wonderful care and supportive care to our patients. So I want to be able to switch gear and talk about an area that has been a bit of an interest since I met that patient, the 54-year-old woman from MSJ, and that has been kind of on the side of my table of doing venous thrombosis, learning more about aortic thrombosis. And the reason I have this interest again is because you've got the largest vessel in the body that is feeding all of the body at 4 meters per second flow. That seems to have the capacity, the body seems to have the capacity to create a blood clot in the middle of that chaos of a blood flow. And not only do that, but also really just attach it to the wall. And then you are basically, once you see it, you're living in this pins and needles of when potentially that clot is going to fly off and cause significant morbidity and even mortality. And so that has been kind of the reason that I've delved into kind of, can I define what an aortic thrombus is, and can we do better in terms of management of these patients? So by definition, when there is a presence of thrombus in the aorta, in absence of any aortic disease, that's an aortic mural thrombus. It can be detected symptomatically because the patient shows up with an embolic event. So they've got a toe or a ischemic limb, or it can be asymptomatic, like the woman from MSJ, where some other finding brings them in, and then the CT scan shows evidence of an incidental thrombus within the aorta. What is the incidence? So autopsy done across shows that there is a 0.45% incident rate in general population. And of those, 17% have evidence of embolization at the time of the autopsy. And in fact, 6% of those people, which is a very small number, are clearly there on that table because the event results in their death. There seems to be a higher rate of females experiencing unexplained aortic thrombus as compared to male, and the average age of presentation is 54, which funny enough was the age of the patient that came to MSJ. On first glance, when a patient presents with aortic thrombosis, and if you have never met them before and they're your first consultation to see, obviously there is a differential diagnosis, and that includes dissection, aneurysm, atherosclerotic disease, evidence of hypercoagulable state, infections resulting in disease or inflammation. So pretty much 6 broad areas of potential reason for an aortic thrombosis. How do we investigate that? Without getting into too much, it really depends on what your history says, because your imaging and your first history and physical exam has the potential to really take out the first 3 etiologies. So you should be able to see, if you have good imaging, to see that there is either a disc dissection, there is aneurysm, or the patient has clear evidence of atherosclerosis. And if not, their history in terms of their risk factors, they are like a 50-pack smoker, they have really bad uncontrolled diabetes, and they have chronic kidney disease, are significant contributors in terms of what are the possible causes of their aortic thrombus. And then moving to the more hypercoagulable state, that is an area that has been, again, an area where the lines have become more blurry over the years. Significant, for us in the venous thrombosis world, I'd like to think that we kind of liked to hug the thrombophilia thing to ourselves and think like this is all venous thrombosis. And it is for the most part true. Probably the only thrombophilia that straddles very meaningfully across venous and arterial thrombosis is antiphospholipid antibody. And so that is absolutely one of the very first things that we should be looking at, because it has the potential to be both arterial and venous. From the perspective of the genetic thrombophilias, the traditional thought is that there's very little contribution from either factor V Leiden and or prothrombin gene mutation. Do they get tested? Yes, in North America, they do, mainly because the patients are presenting at very young age. Although, funny enough, despite the testing, it doesn't really change your management because there's not much you can do about the genetic presentation of that patient. You still go ahead and anticoagulate them. It doesn't change your management overall. Prothrombin C and protein S have some moderate association with MI and stroke. So a patient's presenting at less than 55 years of age, the overall expert suggestion is that go ahead and test them for that. What is the likelihood they're going to have the disease? It unknown, but the anticoagulation management really doesn't change. There is no evidence that antithrombin deficiency is associated with arterial thrombosis, and I have yet to meet a patient who's 55 and has that, but not been diagnosed. So we do not send antithrombin as part of the workup. So for me, that huge slide at the end of the day is all about antiphospholipid antibody syndrome. So that is the one that's likely to give you a significant diagnosis that truly changes your management, because the type of anticoagulation that you offer that patient has to be, for the most part, limited to warfarin. So what happens when you do see the aortic thrombosis? What are the options that the potential options that the patient has? There's 3 treatment strategies currently in absence of any randomized controlled trial. Obviously, medical management, we're going to anticoagulate the patient, open thrombectomy, or thoracic endovascular aortic repair, or TEVAR. The best data that we have is basically based on an observational study of 74 patients. As you can see, numbers are very small. They basically just followed every patient that presented with an aortic thrombus over a couple of years, and they're trying to see, is there a way that they can potentially find one modality of treatment to be better than the other? And the overall answer is really no. It's a highly morbid condition. People do die related to their thrombotic event. A portion of patients who underwent medical therapy, so anticoagulation, eventually did need to go to either a TEVAR or had a morbidity or mortality related to their persistent disease. People did go to open surgery, and that there is recurrence happening despite the fact that there is thrombectomy with an open surgical bed, and that they further had to go on and have a TEVAR later on. There seems to be a better response to TEVAR. So overall, patients seem to have a lower rate of recurrence when they had an endovascular approach, but obviously there's still ongoing mortality associated with a management of the mural thrombus. What does this mean? I think at the end, it means it is going to be a decision that needs to be made at the bedside based on the presentation of the patient, their comorbidities, and whether or not you're facing an immediate morbidity from the thrombus within the aorta. So if there's a high risk that that thrombus is going to fly off and significantly affect the patient with causing lower limb ischemia, that is a decision that in combination with vascular surgery and the patient might lead to a thrombectomy, an open thrombectomy, as compared to potentially what your institution has. Do they need to be, do they have the skills to do a TVAR versus, go to open surgery? And in some cases, there is so much morbidity that anticoagulation remains the only potential option for the management of the patient. So that was to kind of look at the, I was very biased, kind of the area that I have a bit of an interest in, which is aortic thrombus. But obviously, formation of arterial thrombosis is not limited to our, aorta. We continue to see, as you saw with the cases that I semi-presented, events of arterial events in multiple organs and beds. And so the worrisome part of this is that without a fail, it seems to be affecting younger patients. We are unable to identify an etiology, which is very frustrating for a young person. For example, like that 33-year-old physiotherapist. He, one of the things he said to me is like, I feel like I'm a time bomb. Like, how do I live like this? I was sitting there having beer with my buddies, and then I have a stroke. And then people just say, carry on. How do I carry on? Like, I feel like my body failed me, and I have nothing to tell him because I don't know why he has it, right? But clearly it is, it's causing not just, an MCA stroke deficit, but also psychological morbidity related to that experience. They remain a significant diagnostic challenge. And as I said, we don't have evidence in terms of how to manage the patient in terms of their risk of recurrence. We don't have really any evidence-based strategy to predict the risk of their bleeding versus their recurrent thrombotic event. And at this point, putting them on direct oral anticoagulants also remains with limited data. We don't really have any population that have been studied for many moons and many months in a row to say that, we're doing good by, offering patients long-term full dose anticoagulation. And so when it comes to unexplained arterial thrombosis, this is the current expert recommendation for the management of these patients. So step number one is to define the clot. So it is very important to actually establish that the thrombus is within an arterial bed, because there are cases where the venous thrombus is so bad that it is almost a mimic of an arterial event. So there is so much venous congestion that at first glance, it appears like the patient had an arterial event. They're experiencing significant ischemia. This is of main concern, especially in visceral thrombosis, where people are presenting with abdominal ischemia and potentially they're experiencing venous, but there's so much congestion and there's so much, I guess, congestion within the area that you could get tricked into thinking that there's an arterial event. So it's very important to actually go through the history, do the physical exam, and really re-evaluate your imaging modality. If you are finding that the data doesn't fit, really do go and ask for another imaging. Try to establish and figure out where is the arterial bed. And if you have within that imaging, review it and identify whether or not you can see any evidence of atherosclerosis or any vessel wall abnormalities, because that really is going to push you completely to a different area of treatment and management as compared to not having an explanation for the patient. If you are finding any, if the patient is coming in and you happen to have any pathology available, do walk down to the pathologist's office and have them review it for you. Have a look and see if there is any evidence of microthrombi. Is this arterial versus venous? What are the possibilities within the pathology? Is there any evidence of inflammation, vasculitis? Can they explain what is happening to the patient? And if there is evidence of end organ damage, definitely consult an organ-specific specialist to support the patient in terms of managing their ongoing care with the end organ damage. And then obviously, in most cases, we do a literature review because we rely on kind of previously published data to try and see if there is any other ways, to manage the patient in terms of their steps forward. So after you've defined the thrombus, it goes back again to history. So gather the history and see if there's any way for you to identify a risk factor, atherosclerotic, embolic, medication, use of substances, including substance use disorder, cocaine. Is there any evidence that they have vascular anomalies or if they have any disease within their blood vessel that might be either related to their infection or inflammation? And are they coming in with a history that is really nagging for a systemic disease that is yet to declare itself? And so take that history. They're giving you data that fits with a connective tissue disease, but it's not yet, typically fitting into the number of, requirements to be diagnosed with a systemic illness, and keep that in mind. And if they're young, definitely go ahead and do a thrombophilia workup. This is to show, number one, that we're really dealing with very small incidences. So when we're looking at cryptogenic ischemic limbs, renal infarct, mesenteric ischemia, we're looking at very small numbers. And that's the reason that these patients are presenting and remain orphan within their presentation. What is the workup? Again, it's exactly what I basically put out. Like, go through the differential diagnosis, rule all of those out before you decide that this was an unexplained event. And as you can see, there is a lot to be done when patients present, independent of really the anatomical place where their thrombus occurs. In terms of management, really, again, like I said, there is really no randomized control trial. For the most part, everyone gets anticoagulated. In some cases, an addition of an antiplatelet might be considered. But whether you're brave enough to go directly to a direct oral anticoagulant when they present versus, transition them by treating them with the kind of the traditional warfarin and just get yourself into a secure place after 3 months with, a truly tested anticoagulant, and then switch them over to a DOAC. That remains kind of almost a personal choice and dependent on the type of presentation and potentially the morbidity if they fail. So if their DOAC fails. And so this is, again, just to show that within each of these, organ beds, the incidence rate is small, the differential remains wide, and the workup remains pretty significant. So I don't want to belabor the point of kind of taking a history, but just briefly, again, atherosclerotic disease remains a number one cause of a presentation. So sometimes you might not be able to see it within the CT scan, but the history of the patient gives you the story. Do consider embolic events when patients are referred to and they've had partial workup done. Please do go through kind of like check marking, have all the steps that would determine whether this patient has had an embolic event been, crossed out. If not, complete the workup. Makes a huge difference to the prognostication of the patient. Do consider other causes, including the history that was not mentioned before. If they were on a high estrogen birth control that has since been taken away from them and they're now failing to tell you about it since they presented. Were they taking anabolic steroids because they were trying to body build, but they just don't think about mentioning it, and nobody really thinks about asking about it. And do consider thrombophilia in the younger. And then if the patient is really presenting with a significant number of symptoms that don't seem to really be going anywhere, but they're concerning because they're giving you things that are kind of in that realm of not yet defined, like connective tissue not yet defined, but there is definitely a smell to these symptoms and signs, then please go ahead and consider that an underlying inflammatory systemic disease might be the cause. And in cases of constitutional symptoms, do consider cancer as a potential cause for the arterial thrombus presentation. The only other point here I wanted to make is just that we treat the cryptogenic visceral infarcts so slightly differently, and that is around looking at their CBC, if there's any evidence of erythrocytosis or thrombocytosis, and the consideration that extra work in terms of myelodysplastic or hematological malignancies should be considered, and then ordering JAK2 and a flow cytometry for PNH. And never forget to ask about heparin if the patient has been, in the hospital setting within the 3 months of their or had a re-exposure when they present with their arterial event. Treatment, not going to go over it because it's going to be either immediate anticoagulation if they're presenting with IV heparin, depending on whether or not you have a surgeon on board and wants to go into the OR to rescue an organ, and then we transition to warfarin. Again, like I said, I can't really give you any opinion in terms of is it safe to go to oral anticoagulants. Specific to the unexplained arterial thrombosis, we don't have enough data. We make decisions based at the bedside, based on the kind of the presenting symptoms, the potential morbidity of a failure of an anticoagulant. And we also know that nothing is written in stone. So you can go from warfarin to a DOAC, or if you're on a DOAC, you can't switch to warfarin. So we're not really, making a commitment is not like a marriage. You can like break it and go to something else if you find that like new data becomes available, right? So you're not stuck. That's not that level of commitment. Nobody's going to put a finger on it, so put a ring on it. So be comfortable to go back and reevaluate and do every 3 months. So these patients are seen in the thrombosis clinic every 3 months because we do reevaluate. Is there a clean? Are they doing okay? Is there any evidence that they're having a thrombotic event, and have they had any bleeding events? So I'll just want to finish off by mentioning that, the disease process of arterial thrombosis of unusual site or unexplained etiology really comes with devastating consequences. And it's even more devastating because we don't have much data for very young patients who are coming in with life-changing diagnosis. And so the long-term management of these arterial events remains very unclear. And, we make decisions based on, as I said, the presentation of the patient in a collaborative multidisciplinary format. For example, when cardiology or hematology or vascular surgeons have been involved in the care of the patient. The lack of any specific medical specialty taking ownership of a patient that's experiencing a very psychologically distressing diagnosis pushes for the potential collaborative institution-wide approach of kind of coming together as a group and deciding that we're going to provide the care for the patient so they're not kind of left in the wind, because the neurologist can't really add anymore and the vascular surgeon can't add anymore, and yet the patient remains really vulnerable to potential future events. And so this is my bid for saying that a multidisciplinary approach with all stakeholders allows us to provide better care for our patient, but also improve our own institutional experience and hopefully improve our patient outcomes. So with that, I'll say thank you, and I'm happy to take any questions if there is any. Thank you.
Questions for Dr. Rahmani? Dr. Juan.
Thanks, Anna. We have tumor rounds, we have liver transplant rounds, GI rounds with the pathologists and gastroenterologists and surgeons. Do you think we should have, I don't know what we call it, clot rounds or arterial thrombosis rounds? What are your thoughts?
I actually think yes, we should, because although the events are rare, I think there are many venous thrombotic disease processes that would benefit from rounds. Case to point of endocarditis patients who decompensate, end up in ICU, we do a CT scan, and there's like, is this a PE or is this a septic emboli, right? And then where do we go from that? And depending on who is on service with you and who the radiologist is, the level of expertise within the ICU and within radiology, people sometimes are very comfortable calling in and saying that's a septic emboli, that's a bland thrombus versus not. And so I think we see enough of that by itself might be an indication for us to have a collaboration and collaborative group like a clot rounds group, but even more so because we're a vascular center. We're bound to see these patients once we start to look. And so if we form that collaboration, I bet you that we're going to see way more patients than we even realized existed. Yeah.
Dr. Gador.
Thank you for that wonderful talk, Dr. Rahmani. And it's a really disturbing and devastating clinical problem. Kind of a two-part question. First is, what's your, is there anything in the state of the art for almost like a ROTEM for thrombotic events, to see what the clinical behavior of the clot is? And then it was kind of interesting with all the vaccine-induced thrombocytic or clots that had occurred, and then I guess it's non-heparin induced hit.
Mhm.
As it relates to biomarkers, are we just too far out to see the biomarkers that do associate with these clots, that there is some sort of transitory immune activation, especially if people can get hit without heparin?
Yeah, no, I didn't even get into that because there's massive, not massive, but there is definitely a significant number of literature publications since COVID by itself as an infectious process, and then introduction of the vaccines has led to, as you mentioned, kind of arterial events. And what does all of that mean? The research in that area continues. So there within the COVID area, there is ongoing research. I didn't really delve into it too much because I knew that the area was going to be really too wide, and I didn't really consider it to be an unexplained because there is clear etiology that drove the arterial event for sure. It is potentially helpful because we know that there is immune thrombosis, and there's been a lot of attempts to modulate immune thrombosis when patients are in ICU and they're experiencing, a septic event, and we know that there is an overwhelming response. As part of that response, the innate immunity steps in and starts to just do damage because there's no control over what the body is doing. And so my hope is that that would be the area where we're going to get the most amount of results in terms of understanding immune thrombosis and how it looks at the level of the typical sepsis and then at the level of induced immune response, which is with us giving a vaccine potentially. I don't know if that answers your question. And then I forgot what the first one was.
Just with some sort of advanced testing for, is it a red clot or a white clot or some sort of protein-like thing?
Yes. And you know what? And in fact, I think that we should, because we are probably at the best in terms of our embolectomy, thrombectomy that we've ever been, right? Because with the idea of door to needle within this many hours for the brain and within this many hours for the heart, that is the time for us to be able to actually get to that clot and look at the pathophysiology of it. And then potentially longitudinally follow that patient and say, you know what, when they're coming in with a very fibrin-rich clot, the antiplatelet therapy clearly is not making a difference because we're seeing repeat presentations and recurrence of their acute coronary syndrome. We should be considering other types of treatment in addition to an antiplatelet, as compared to a patient who walks into the door and has a red thrombus and they get on their aspirin, we never see them again. And so I think that's an excellent idea, and I'd be interested to see if that gets taken up by our neurology and cardiology colleagues in terms of directing future treatment options at a molecular level. Yeah.
Any other comments or questions? If not, I have one. The clotting process is in response to something. So do you think that there's an anatomic problem that's resulting in these processes beginning, whether it's arterial or venous, and are we missing it? I mean, we do see cholesterol emboli, we see cholesterol plaques, we see those sorts of things, but do you think that, why do we have certain vessels as the site for these thrombosis? Do you have any thoughts on that?
I don't have an answer to it, but I absolutely think that there is an anatomical difference in terms of vulnerability for thrombus formation, because we're seeing it from the data of even the type of clot that gets deposited is different when it's in the brain as compared when it's in the lung versus in the heart. So clearly the body has, what I like to think, a sense of where I am when I'm making this clot, and I'm going to make it different if it's in the brain as compared when it's in the bowel. So the only way for us to be able to, for the body to make that decision is that there are local signaling that occurs that tells within that localized environment that this is the brain. Mm-hmm. And we know that at least at the level of the brain, the level of deposition of different inducers of coagulation cascade are different. And so, for example, the level of tissue factor is massive in the brain. And that is one of the reasons that we think potentially warfarin, causes a significant number of higher level of hemorrhagic events as compared to the direct oral anticoagulants because of the way that warfarin functions. So there is definitely local, I believe, and I have no evidence for it, but that there are local communications that are happening. We just haven't discovered what they are. The same way that, we eventually figured out that immune thrombosis, it is something the body does because it's part of its innate response to damage.
Yeah, and I was thinking that there may be the connective tissue in these areas may actually be the signal for that area to be vulnerable, but I don't know. Any other comments or questions? If not, I can hope that you've enjoyed this as much as I have. Thank you very much.
Thank you. Thank you.
Yeah. Impressive.
Thank you.
That was so good.
Thank you. Oh, sorry.
I like plagiarized.
You're more than welcome to play.